Good afternoon, everyone, and thank you for joining our webinar on the state of health equity in cancer. My name is Ashley Brown. I'm the Strategic Director of Health Equity in Cancer for the Strategic Director of Health Equity for the American Cancer Society. Thank you for joining our webinar this afternoon. We have some illustrious speakers today, and today we will be talking about diversity and inclusion in health equity research, and we'll be receiving an update from Dr. Ellie Daniels. Dr. Robert Nguyen will be giving us a keynote speech on the state of cancer and health equity. We'll have a brief Q&A with Dr. Robert Nguyen, and then we'll have an ACS health equity update and some closing remarks. So before we jump into that, I want to show you a brief poll. Hopefully everyone can see it on this screen, but this will help us inform the future of our future webinars. So if you could briefly just fill out and complete the poll, that would be great. We want to know how you're viewing health equity, how familiar you are with the concept of health equity, and your ability to impact health equity through your work. And we'll give you a few seconds to complete the poll. I see lots of folks completing it. And when we get those numbers up a little bit more, we'll move on. Just a few more seconds. Again, this will inform our future webinars or future learning opportunities around health equity. We're almost at 80%. When we get to that 85%, we'll close the poll. And you can honestly answer on this poll. Again, this is being used to inform our future learning opportunities. Okay. Thank you all for completing that brief poll. We're going to ask you at the end of this webinar to complete that poll again. Maybe you learned something during this webinar that may have changed your answers. Now let's move on to the good part of the webinar. I want to introduce Dr. Ellie Daniels, Senior Vice President of Extramural Discovery Science for ACS. She'll be giving us a brief update on our diversity and inclusion and health equity research update. We know that to help advance health equity, we need to ensure researchers reflect the communities that they serve, and we need to fund research that helps address cancer disparities. So Dr. Ellie Daniels will be giving us an update on diversity and inclusion and our health equity research. And as Senior Vice President for Extramural Discovery Science and Senior Scientific Director for Clinical and Cancer Control Research, Dr. Ellie Daniels oversees the EDS programs and research program development, pre-application management, peer review, and grant management in the areas of cancer prevention, screening, early detection, access to care, cancer treatment, palliative care, and survivorship. So I will turn it over to Dr. Ellie Daniels to give us this update.
Thanks, Ashley, and good afternoon, everybody. This time last year, Ashley asked me to provide an overview of our plans that align with our enterprise-wide diversity, equity, and inclusion goals. So today I'm going to give you an update on our progress. Next slide. So last year, as you recall, I presented a new program that we started to increase workforce diversity. And it was kind of like a perfect storm. You know, we had this heightened sense of social injustice as the pandemic rolled out. we had an influx of restricted funds and an increased budget to start some new initiatives. So we started with college students. And so here are pictures of the interns that participated in the internship last year. Next slide. So there's 3 initiatives that we started in the Diversity in Cancer Research Program. One is targeting underrepresented minority college students. The other is supporting minority investigators to provide pilot grants. In the 3rd initiative, the institutional development grants are funding to provide infrastructure support for research and career development at minority serving institutions. We also reflected on our cancer research, health equity research since 1999. And as we were entering the 3rd decade of funding, we thought about what we might do differently to advance cancer health equity research. So we started a new request for applications, cancer health equity research centers at minority serving institutions. I'll talk about a little later. Next slide. So here is a summary of our progress. 32 interns participated in intense cancer summer research experience last year, and they are continuing to be engaged with their mentors through May of 2022. We're anticipating 70 interns to participate starting the summer of 2022 in June. And we have a request for applications coming out in October for internships for 2023. In terms of the minority supplements, we awarded 19, and we plan to fund at least 20 per year going forward. With the Diversity in Cancer Research Institutional Development Grants, we were able to award the 4 HBCU medical schools, and we also are funding 2 professors, 2 of our research and clinical research professors with each school. So a total of 8 professors will be serving as institutional mentors and coaches for the HBCU medical schools. So we anticipate in 4 years, we'll have launched 104 cancer research careers with this first cohort of institutional development grants. And we have another round of requests for proposals. Actually, it's in July of 2022, not 2021. In terms of the Cancer Health Equity Research Centers, we were able to fund 4 in December, and the next round of funding for those will be later in the year. Next. So wanted to show you a brief video. It's only about 40 seconds related to the value of the internships from the mouth of an intern. So Ashley, could you click on that brief video?
Hi everybody, my name is Ayo. I'm a sophomore at the University of Maryland in College Park. And last summer, I had the incredible opportunity to be a part of the Diversity in Cancer Research Program by the American Cancer Society. As a Diversity in Cancer Research intern, I had the opportunity to build strong relationships with the private investigators and other undergraduate researchers. So much so that I developed a passion for translational cancer research, and now I'm considering going into an MD, PhD, or a PhD program after undergrad. All in all, I want to thank the American Cancer Society for developing such a holistic and in-depth research program. Thank you. Hi everybody. Okay. My name is Ayo.
Thanks. So that, that's just one of the heartwarming stories of initial impact from the interns. So for the summer of 2022, we awarded 12 institutional research grant grantees to participate in the internships, and they'll be supporting 4 to 8 interns each. And so here are the institutions that were awarded this year. Next. So the new RFA, Cancer Health Equity Research Centers at minority serving institutions, we really are trying to drive solution-based cancer health equity research focused on the social determinants of health, which you're going to hear about from our guest speaker. So I won't go in detail, but in the next slide, I'll show you the 4 institutions that were funded. So, you know, we're happy to announce that these 4 were funded, and we've invested over $6 million in funding. And as you can see, each of them are addressing a cancer health disparity issue that's really passionate to them and their local community. And so here are the 4 institutions and what cancer health equity issues they're addressing. So, you know, we'll hear more about their progress as they start their research. So in terms of programmatic context, you know, we can do, it takes a team to get all this work done. So I've included the programmatic contacts as well as marketing communication. They've already developed kind of shovel-ready material. If folks, you know, so folks don't have to start from scratch talking about the program. There's an FAQ and other resources that are being updated on Brand Toolkit. Development has dedicated staff that will help folks who want to help raise the funds. And just a special thanks to our philanthropy colleagues, Crystal Fetterspill and Chris Thomas. You know, they were the ones who really help us start the diversity in cancer research intern programs, and are still raising money to support those. So with that, I'll answer questions at the end of the webinar. Ashley?
Yes, thank you, Dr. Daniels. Maybe you can take this quick question before we move to our keynote speaker. What are we doing as an organization to ensure diversity in clinical trials? I know ACS CAN works to advocate for more diversity in clinical trials, but is there anything from the research side that you could speak to?
Well, we're supporting research that health equity research, and some of that is clinical trials. And so those investigators are including underrepresented minorities, women, et cetera, in clinical trials. We have a couple research studies that's specifically addressing increased diversity in clinical trials related to some of the payment issues. And we're also launching a new clinical trials enabling RFA that'll be coming out later in the year. So some of that will be incorporated, and we're actually working with ACS CAN on some initiatives related to increasing diversity in clinical trials that'll be incorporated in the new RFA.
Thank you for addressing that important question. We know that increasing diversity in clinical trials is one way to advance health equity. So now we're going to move on. Thank you so much, Dr. Daniels, for providing that update. Oh,
you're welcome.
Thank you. Thank you so much. And we're going to move on to our keynote speaker. If you have questions for Dr. Ellie Daniels, please put them in the chat, and we may be able to address them at another time. But we wanted to move on. The title of this webinar is The State of Health Equity in Cancer. And we think it's so important to highlight cancer disparities, but also to make the connection between the root causes of cancer disparities and how they come to be, right? We can't just talk about and highlight the disparities themselves. We have to talk about the root causes so we can work to address those disparities. So I want to introduce our keynote speaker, Dr. Robert Nguyen, who is the director of VCU Macy's Cancer Center and an ACS board member. In this position as the director of the Cancer Center, Dr. Nguyen oversees a designated cancer center by the National Cancer Institute and provides outstanding cancer care, conducts groundbreaking research to discover new treatments for cancer, and offers high quality education, training, and community outreach programs. In addition to directing the activities of more than 250 researchers and physicians from 39 academic departments from 9 schools and 1 college at VCU, he also manages a research laboratory at VCU. His current basic science research, which has been supported by multiple National Institutes of Health grants, focuses on the cellular pathways that drive the development and progression of lung cancer and the role of cell division arrest in lung cancer. He has authored and co-authored nearly 800 published manuscripts and peer-reviewed academic journals and has contributed 5 chapters to books. So again, we are so excited to have Dr. Nguyen come speak to us today. He is an ACS board member and he has been committed to community engaged research centered on eliminating cancer disparities. So Dr. Nguyen, I will let you take it from here.
And thank you for that introduction. I'm going to share my screen in a second. But before I get started, I want you to know that I am, listen, if love and science is wrong, I want to be right. And I know that when you look at what has happened with the evolution of science, it certainly has benefited. And in fact, we have the data to support that. But here's what I know. Even though I know that, for example, clinical trials are critical, and that we all see clinical trials as a standard of care, a continuum of care, if you will. When it comes to getting everybody represented, we have some obstacles. From the fragmented navigation to the issues around transportation, which the ACS is trying to address, to the issues of trust and whether we're even measuring our own trustworthiness, along with the criteria that ultimately, even when one is ready, may, for many of these trials, may be excluded. And last but not least, assuming that because I'm in a package that may be different than the majority, that I never get asked to be part of a clinical trial. This talk's going to be a little bit different because I'm going to give you a little bit of a heads up. This talk is going to be not so much about why the biology of things are an issue, but the structure and how we contribute to that structure. So I want to start off by saying that I am really proud to be on the board of the ACS under the national leadership of Karen Knudsen, and many other people like Ruby King, and just many people just all over, and people who've come way before. The ACS has been, and ACS Can with Lisa and others have literally been out here beating the drums in some cases before this was even a sexy topic. So this is really going to be more of a concept of what's actually happening at the level of structure and why I think it's time for a call to action. As I've said, I'm on the board of ACS and Longevity. I will not be discussing any off-label use of any drugs or investigational use in this presentation or any others. COVID was really, in some ways, an opportunity for us to take a pause to understand that while things were certainly getting better for some, things were not always getting better for many others. And so I want to start this conversation with just so you all know where I'm coming from and why I don't use the word health equity. And I know that may make some people uncomfortable. For me, when I think of health equity is a principle. It's a principle of an underlying commitment to reducing and ultimately eliminating disparities in health and its determinants. When I speak of health differences, I speak of the differences between two groups, Black versus white. But when I speak about health disparities, to give you a concrete example, means to me the following. that we know that there is a difference, for example, in Black versus white men outcome in the United States from prostate cancer. However, we know through systems of the VA and some other things and other efforts throughout the country that when access and the quality are equal, and when the access to trials and high impact and high quality care are spread equally across Black versus white, you don't see disparities within some systems, particularly in the VA systems, from Black versus white, poorer outcomes in prostate cancer, for example. That's a disparity. That disparity is rooted within the context of social justice, because it means that your biology, while certainly important, and many of you have probably been hearing, and I'm going to continue to say that your ZNA is much more important than your DNA in your biology and in your biological outcomes in most cases. That ZNA is your zip code neighborhood of association and the place in space. And hopefully I'm going to make an argument for you why we need to stop talking this craziness that simply because I'm in a package that's brown, that somehow I'm just biologically more predisposed, without taking into account place and space. So you'll be hearing me talking as aligned with the ACS in the context of addressing health disparities and the context of social justice issues. Now, I don't want to make any mistake of having any of you think that any of this is new. We didn't just discover this with the advent of COVID, with the onset of COVID. In fact, the definitive writings were from W.E.B. Du Bois, a great social scientist of his time, who wrote in 1899, that is correct, 1899, the definitive paper called the Philadelphia Papers, in which he extensively described and portrayed the disparities, the inequities, the uneven distribution of not only wealth, but education, poverty, and health, that was simply based on one skin color. So when I think of health disparities and health disparities research and what we're going to do about it, I have to say it's like weight loss. We all understand that the reality is that we know there are benefits documented by losing weight. We probably have one of to 10 or 20,000 choices of picking a diet that if we did what? Committed to it, we would lose weight. I submit to you that this issue in and around disparities is similar to weight loss, and that we understand and have publications and documentations of understanding the benefits to our society, the benefits not only to our own individual health, but getting beyond community health to the national health of actually having health equity put in place and health disparities reduced. And believe it or not, since the 60s and 70s and 80s, we've had programs in place and blue ribbon panels from the time of the 60s that actually have not only described these blue ribbon panels of how to address these issues, but even had field testing that can show that they work. It's not so much that we don't know what to do, it's that we don't have the consistent and committed will. I told you that I love science, and I do. And this is not a conversation of an either or. It's either, we focus on the community or it's science, because that's a false argument. My love for RNA binding protein, my love for protein methylation, all stems from my love of basic science. But let's get this straight. In 1950, right? If we look at the big thing that changed science, it was the discovery by Crick, Watson, and Franklin, as pictured here in photo 51, the first evidence that for the first time, humans can now investigate the nature of human cells. By understanding the nature of human cells, it unleashed a science that resulted in people like David Baltimore understanding what reverse transcriptase was, and Phil Sharp understanding things about the split genes that led to what? A real robust foundation of us even thinking about how to do and how to tackle cancer. This research in 1950 was paradigm shifting in all sense of the words, because prior to that, we had been focused on issues of matter and energy. In 1950, we opened up an avenue in which we could actually do science. But there's this blind spot. This is why grace and humility, even with the latest discoveries, matter. At the same time, Watts, Crick, and Franklin were opening up the box of being able to understand DNA for the first time. We also had George Gay, who at Hopkins was the guy credited with discovering the Henrietta Lacks cells, the HeLa cells. You all know the story about Henrietta Lacks, who checks into a hospital in 1951 with cervical cancer and then ultimately passes away. And then ultimately her cells are recouped. And then, again, the message goes, Jonas Salk uses them for polio vaccines. We start making clone cells. We've actually understood the ability of how to make cell lines that ultimately others, Jane Cook Wright and others, would use down the line to be able to come up with therapies even for cancer. This story is sometimes sanitized in a way in which we just sort of look at that as just happenstance, but let it be known that Dr. Gay had been working on this for a very long time before he even ran into Henrietta Lacks. It's just that Henrietta Lacks was the first of his 40 to 50 patients in which it worked. And this isn't a story so much about Henrietta Lacks, but I want you to follow me on this, that as a result of discovering those cells, there were big businesses, the development of polio, the development of other drugs, in which not only did the discoverers benefit, but their generations of children and their children's children, in some cases, benefited from these patented discoveries. Discovering that there was something magical about Henrietta Lacks' cells, because Dr. Gay didn't just run into Henrietta Lacks for the first time and says, I'm going to do this, and come up, as I told you, 40 or 50 other attempts. There's something special about her cells that allowed us to grow and to develop all these things. And yet, while other people were benefiting, her family was not. Her generation of kids and their kids did not benefit. So while I love science, I also understand that there's sometimes a blind spot. But this love of science has led to some good things. And in fact, it has reminded me that when one wants to do big things, we can. 1971, as part of the war on cancer, we created the first, with the National Cancer Act, we created the first NCI cancer centers. There were 3. At the time, I believe it was Memorial Sloan, Roswell, and MD Anderson. We've now grown to 71. And there is no doubt that the belief was that by us in the 1950s unleashing the power of science, the thought was that, as President Nixon is signing that, by 1981, we'd be rid of cancer. Now, the interesting thing about that is that many of you know we've lived longer and past 81, so we know in retrospect that was a little naive. This is the first clue that while science is absolutely necessary to being able to fight cancer, it in and of itself is not sufficient to eradicating the disparities that exist within cancer and cancer care. These are data taken from the ACS. And as you know, this is one of the things that I'm most proud about. that when people go to reference most of these issues around how is the United States doing and what's the cancer incident death rate, we're always going back to our to the ACS and those reports. Let me make this easy for you in telling you that when it comes to people getting cancer and dying from cancer, African Americans to this very day tend to have more cancers and die from them more than any other group in the United States. And by the way, more African American females die than any other groups of women within the United States. Now we can look at disparities in multiple different ways, not just African American or Latino, but we also understand that while we've made some progress, certainly the Black-white ratio of deaths from cancer is reduced from back in the 1990s, where it was more than a third. That's now been cut down to roughly about 15 to 16%. But those disparities still exist. They not only exist for people who are come from diverse backgrounds, but they also exist for young Latinos, Latinx, who kids and teens are more likely to get leukemias and actually have poor outcomes. They exist for bisexual women who actually have poorer outcomes than heterosexual women. They exist even in geography, where we know that a 75-year-old white male from Utah and a 75-year-old white male from Kentucky, that the white male in Kentucky is 3.5 times more likely to get lung cancer and to have a poor outcome. As we think about breast cancers, we know that cancer can obviously affect anyone, but it doesn't appear that it's affecting everyone equally. Whether we're talking about breast cancer, whether we're talking about the disproportionate number of African Americans versus white men in prostate cancer, or the fact that as we're talking about rural communities, that they also are doing less well than many communities in the cities. I'm going to make the argument that place and space matters. And this is just a little example of just an experiment. If one, this is Chicago, looking at the state of Illinois, if you were to look at the life expectancy in the state of Illinois, it looks almost like everything in the United States. If you then broke that down to looking at Cook County, you would actually see no real difference between Cook County, which is a large county, one of the largest counties outside of California in the United States. It doesn't really look all that different than the United States. And even if you looked at the entire city of Chicago, one would not make the argument that it looked radically different. But yet, when you go under the hood, this is what I love about disparities. Disparities is just when you now look at something that's disparate, it allows you now lift the hood and go under and find out what are the factors contributing so you ultimately can come up with an intervention. This is an easy one in which people living on the Loop, that's when Oprah Winfrey or Keanu Reeves would come back to the Chicago area. They're going to the lakefront area. This is the area called the Loop. The life expectancy there is 85. If you literally went 4.5 miles west, the life expectancy decreases to 16 years less of living than in Loop. And sadly, if you go 8.5 miles south of the Loop, in an area called South Chicago, where Bernie Mac and others people have come from, the life expectancy is reduced by 30 years. Now, before you start talking about the reality is that this is associated or related to gun violence and all the rest of that, let me tell you that we've looked at that and understood definitely that that is a negligible contributor. We also understand that this happens, a paper that Dr. Weiner, who's the head of the Cancer Center at Iowa, and I have put together, that these disparate groups share common disparities. You look at some of our rural areas in Iowa or rural areas in West Virginia, or Kentucky, or Mississippi, you can clearly see that your place and your space matters. This is the concept of zip code neighborhood of association and the importance it has of where you live in some ways has a even more significant impact than your DNA on your overall outcome. Since COVID, many of us have been brought to attention, well, how did these things actually happen? Well, let's just quickly wrap this up by saying structures were put in place. Structures like the ones that were created by Homer Hoyt, that redlining, which we subsequently called in 1960, which was created in the 30s to ultimately keep people, separated, actually sanctioned federally based on essentially what was the soft science at the time called eugenics. The blue and the green area is an area of Richmond in which those were places where the desirables, meaning white and others, who based on the science at the time, the best science they had of eugenics, said that based on the predictive values and other things of eugenics, those folks would be able to pay their loans back much faster than the people who were living in the yellow and the pink over here, or the red, who tended to be African Americans. And that was a judgment based on some eugenics. That was, by definition, a structure. Now, independent of the redlining, it turns out that those communities that were in the pink and the red thrived despite that redlining. In fact, in an area we call Jackson Ward here in Virginia, on the East End, as we refer to it, the East End, not desirable, the West End desirable, on the East End, it thrived with its own banks, its own grocery stores, its own commerce, its own et cetera, that it was dubbed the Black Wall Street at one time. So it wasn't so much the redlining, but the urban renewals programs, which devastated many of these communities of color. This was the deliberate building, as one would say, white roads through black bedrooms, which crippled and in some cases completely obliterated many of these communities. Now, why is this such a problem? This is why I want us to get out of the concept of talking about people as just simply being more predisposed without understanding the issues of place and space, because we know that where you live matters. We know that those roads being closer, and this is studies done by Victoria Sewell now and many others down in California, that the closer you are living to the highways, the more exposure you get, the more exposures we can even track on a national level, the more cancers. We also know that in these areas, in addition to the roads being built that devastated many of these communities, we had many industries and other businesses that were placed there because it was seen as being undesirable areas. These industries added to the hazardous area. We also know that the bottom line is that we also know that particulate matters 2.5 are over the United States by work done by Tussum and other people. We understand that these exposures you can map and are disproportionately in underrepresented communities. So let's stop talking about just simply because you're a woman, or simply because you're Black, or simply because you're. Let's start talking about the fact that your biology, 20% definitely has single mutations, point mutations, deletions. And these are the things that we identify with cancers that we can treat. But let's not play that the place in space also can impact your DNA in a negative way, increasing our risk of cancer. Now, I could be sour about this, but I'm not. Because I know the science is starting to wake up and understand that in addition now to, in the 1950s, we were able to understand the nature of the human cells. We are now understanding the nature of the human cells in the context of the science of data of place and space. And I think the intersectionality of place and space in biology is going to allow us not only to come up with new drugs, not only to come up with new technologies that ultimately will lead to different interventions, but will allow us to actually be much more focused on the social determinants of health, which were, by the way, created by structures, to be able to identify them quicker, to be able to identify them by areas of small area analyses so that we can do more for our communities. We can understand that communities are at risk and do more active screening, do more focus on transportation. And so I am not dissuaded at all about the possibilities of our progress. I'll end with these last two slides. In 1969, there was a great thing that America was feeling very proud of, that is the Apollo 11 launch, which was, for some of you who don't know, is the first time we put a man on the moon. This picture is depicting the Reverend Abernathy, who went arm in arm and shoulders with Dr. Reverend Shuttlesworth and Martin Luther King, a civil rights giant who on the eve made such a ruckus and a protest that even the people from NASA had to come out and says, listen, this is an important launch. How can we actually get you to stop protesting? And he said, well, just talk to us. Thomas Paine, then the deputy of NASA, comes out and talks to Reverend Abernathy, and they're having an exchange. And Reverend Abernathy says to him, listen, it is not that we're anti-science. It's not that we're you're putting a man on the moon. We understand that for the globe and for the world, and it's a message to the communists. It's also a message of our dominance of our science knowledge. But why can you do that? But you can't tackle some of the issues that we've just been addressing in our communities. And without missing a beat, Dr. Thomas Paine said, because it is easier to put a man on the moon than it is to address those issues. In 2021, it still appears that it may be easier to put our neighbors in space than it is to address these issues. So as I think about what it is that we're trying and attempting to do, I'm convinced, not dissuaded, that with the use of data, both large and small, and with an ounce of humility in understanding that sometimes all the new technologies that we use and all the new miracle drugs that we have inadvertently will increase disparities as opposed to reduce it. I'm of the mindset that the ACS is clearly prepared of, one, recognizing that this is an issue and addressing these issues by many of the things that we do today. I also think it's an opportunity for us to throw our arms around recognizing that to get diversity in clinical trials, we're going to have to do things differently, and also to reduce disparities wherever they exist. The science is great, but the science plus the understanding of place and space and the policies that would go along with that, the policies that make it easier to get access to care, the policies that make it easier for people to not actually have to make the decision of not going because they don't have transportation. These things also matter. So with that, I'll stop and just say thank you.
Thank you so much, Dr. Nguyen. That was inspirational. I'm so happy that you ended on an inspirational note, because as an eternal optimist, I believe that these disparities can be addressed as well. I think we have one comment first. Someone said, great perspective on health equity differences and health disparities. Very insightful observation. Social injustices range beyond societal laws, but can also impact people with cancer due to systemic racism that creates barriers for standards of care. So just kudos on acknowledging that and separating disparities versus health equity. I want to ask you a specific question about something you mentioned early on in your presentation. You talked about blind spots, and I want to hear from you. How do you think can scientists be more intentional about addressing blind spots in their work? And I would say scientists or ACS staff, ACS volunteers, or our partners as we're doing our work. How can we be more intentional about addressing blind spots? Because not everyone has the experiences that we're talking about. Sometimes they may not understand the barriers that people face in their everyday lives. So how can people be more intentional about addressing those blind spots?
Yeah, that's a great question. And I'll start off by sort of saying that we all have blind spots, including me. But if we were actually in any other team, they would be saying, well, you need somebody who could actually help you identify those blind spots. For us, it's the community. And I think whether you're ACS staff or whether you're on the board or whatever you're doing, the reality is, I'm going to tell you what my grandmother told me, that having the two most powerful tools of actually being able to do something big is to have grace and just a touch of humility. It's when you don't want to hear things, right? They say comfort and growth do not coexist. But many of us, whether we're staff or on the board, sometimes we like comfortable. Comfortable feels good. But being occasionally wrapping your arms around or having conversations with someone that says, you know, I think you guys are thinking about this okay, and I can see, but you have a blind spot, that too is healthy. That makes us better. How do I do it and how am I encouraging it? More direct conversations with folks within the communities that we say we're impacting. And here's what I mean, not just bringing folks to the table. And I know people are like, what? Not just bringing folks to the table. Centerpieces are at the table. Centerpieces at a table are incredibly beautiful. And sometimes they become the center of attention, but when the party's usually over, they're somewhere in the corner and everybody else is doing their business. That is sometimes what we do with our community. I don't want to just bring folk at the table. I want to actually have them involved in setting the table and in what comes after we're done at the table, almost at every level. So one of the things I do think we can do better, all of us, is being a little bit more, having a little bit more ounce of courage, of vulnerability. Renee Brown say that vulnerability is an act of strength. It's an act of courage. And so us to be more vulnerable at the ACS and understanding that post George Floyd, we too have blind spots. And that we should care, not just me as an African American caring about African Americans, but other people as well. The people that live in Lynchburg and Martinsville, for me. Stretching beyond our comfort zone is going to be something that I think we're all going to be called to do if we are going to get better. So that would be a start. There's a whole litany of list that goes with that, but I'm going to keep it short.
I appreciate that, but I'm going to remember vulnerability is strength. So one thing, another question from an attendee says, for Black men in prostate cancer, any suggestions to increase screening and early detection?
Yeah, let me tell you, yes, yes. I think back in the day when we were having some prostate controversies and stuff, I understood that. But I'll give you a quick example. When we were right in the midst of the prostate controversy, whether to get screened or not, I was in the 20th ward there on the south side of Chicago. And in that 20th ward, they had three times more African-American men dying than the rest of the state and the rest of the United States from prostate cancer. This is where rules, even as we come up with them with the ACS or United States Preventive Task Force, I think we're going to have to actually start employing smart rules, smart guidelines that are living guidelines for your community, as opposed to, as I told you, if I didn't know better, the people in, for example, the 20th ward, as I showed you, 8.5 miles, Inglewood, 8.5 miles away from the lakefront or from the loop, are included in the entire state. So if I looked at the entire state, I'd have no reason to look at Inglewood. If I looked at the entire county of Cook County, I'd have no reason to look at Inglewood because it was. So what I'm saying to us is that we're going to have to get more aggressive about picking out those pockets in which we do see higher spikes of prostate cancer, and then being much more aggressive about our interventions and education efforts. This is where I think the ACS can come up with not only just general guidelines, but precise guidelines. The way we do precision medicine or precision community approaches is also how I think we should be at least scratching the surface on how we can do that for our most at-risk communities to get the education, get the data, and then the intervention and the access.
Thank you so much. And this is my final question, and you kind of touched on this a little bit. Do you have any advice for ACS staff or volunteers who are working closely with community members to help them build trust with folks to ultimately reduce cancer disparities?
Yeah, for real, for real. Have the humility and the vulnerability to look at our own institutional trustworthiness. We always talk about building trust. We've been building trust for 50 plus years. But the question is, how have we ever taken a pause and measured our own institutional trustworthiness? Sometimes when I ask that question, people go, well, it usually ends up with, we haven't. You know why? Because we have said, well, what's not measured is not done. And most of our organizations, including the ACS, have not come up with metrics and measures of trustworthiness before we even interact with our communities. So again, I actually think I'm the most excited about being part of the ACS because I think from our staff to almost everybody that I know that's a part of the ACS, from your senior leadership at the national and regional, people want to get down. People are tired of cancer and understanding we now finally have some tools like immunotherapy, molecular targeted therapies, and other things. But those are going to be a piece of the puzzle. It's going to be us building a trust with community, gaining a trust with community, being connected to communities, having our staffs actually do that little extra when you're tired and you just say, well, okay, maybe I'll put in an extra half an hour, right? Those things will ultimately make a difference in making sure that we are doing exactly what we want to do. Reducing cancer, getting more people access to great care, and giving people a fighting chance with our new knowledge that comes by way of research and clinical trials. I think we have an opportunity to not follow the nation, but be the leaders in the nation about how to do this doggone thing. And I'm glad to be a part of it.
Well, I think we'll end the conversation on that note, Dr. Nguyen. We so appreciate your time and your energy around this topic, and as serving as an ACS board member. Thank you for your commitment to reducing cancer disparities, and I think you gave us a call to action, right? To be vulnerable, to listen, to show up to the table and to bring others with us and to listen to them as well. I really appreciate, and I know we all appreciate your time today. I see that we have some more questions, but maybe I'll send those to Dr. Nguyen via email and have them answered that way. But thank you so much for your time today.
Oh, I have to say, you know what, thank you for the invite. I really appreciate having an opportunity to meet with you, and I'm glad I get to represent you. And hopefully, as we hopefully get back to doing things live, I'll be able to meet and discuss these issues even more. So thank you so much.
Thank you. All right, so the next order of business is just to provide everyone a health equity update. So I just want you to know that I'm a part of the health equity team, and our team provides tools and resources for all of American Cancer Society and ACS CAN staff and volunteers to help you advance health equity. So I just wanted you to know that we'll be releasing a number of resources and tools for you in the coming months, one of which will be a data brief. Data briefs highlight our cancer disparities by population or specific cancers. And then it also addresses how we can reduce those disparities on the other side of the document. So it's a helpful resource for you. And we will be releasing the AAPI, the Asian American Pacific Islander, a data brief in May. So look out for that resource. And so I just wanted you to be aware of that. And now I want you to take a few minutes to complete the poll again. Maybe you learned something new and different from this webinar. Maybe you just increased your knowledge and your skills. Maybe it's motivated you to act. So if we could bring up that poll and we could have folks take a moment to think through some of these questions to help inform future webinars as well. And we'll wait till we get up to that 85% before we close the poll. Just imagine some Jeopardy music is playing right now. Again, if you have any questions for Dr. Nguyen or the health equity team, please put them in the chat. We'll answer them offline. I want to thank everyone so much for participating in this webinar. This is the first health equity webinar in a series of webinars that we will be having over the course of the year that really address some of those systemic issues that impact cancer disparities. And I know that you are going to be excited about our future guest. We will have another webinar in May to also celebrate Asian American Heritage Month. So be on the lookout for that. And I think we are done with the poll. Thank you all so much for attending this webinar and completing our poll. We really appreciate your attendance here at this webinar today. And we will be in touch. Have a great afternoon.